Mike. All right. Welcome, everybody. Let me start by thanking everybody in this room. Those of you who are contributors to children's hospitals in your own communities, and those of you who care about children's health, there's a special place in heaven for you, I'm sure. And especially children's hospitals around the country, because we all know that this is part of a larger movement to try to increase awareness on children's health, but it starts locally. And there's an old mantra when I grew up, which is think globally but act locally. That's what you all do by supporting children's hospitals around the country. So I'd like to start just by saying you all should thank yourselves for everything you did here. In particular, in this week of mourning for what happened in Aurora, let me thank the two people here from the Children's Hospital of Colorado near Aurora who've been so helpful during this crisis, the Children's Hospital. I know we have Chris Schmerling here. Are you around, Chris? And Steve Winsett. So thank you all very much for what your hospital did. This is really an unprecedented gathering. I don't think it's happened before, of this many transformational leaders committed to children's health. And what you're doing is putting children's first, and it's important because what you do also ripples into the larger policy-making arena where political leaders consider the impact of children on every one of their policy choices. We also want to look forward to a world in which quality care and improved health outcomes are accessible to all. We at the Aspen Institute try to focus on values-based leadership, but we also have a saying about thought leading to action. We try in each one of our programs to say, okay, now what specifically are we going to do? And when we do thought leading to action, whether it's in our Crown programs or our Young Leaders programs, it starts with community. It's go back to your community and help implement some of the thoughts that we were talking about this week. It's great to be talking to an audience like you because you're already so involved in your community. Let me start. Everybody, I think, knows everybody on the panel. Susan Packard-Orr, we have Phil Pizzo, Alan Gutman, and of course Cindy McCain. Let me start with you, Susan. We've had a 90% reduction in mortality, I think, in U.S. and Canada. What do you see philanthropy doing to push this transition, and are we moving fast enough?
Well, one of the things that's happened over time is we've moved away from the acutely ill child with infectious disease, and now I think a majority of the children who are in our children's hospitals have chronic disease, and this opens up a whole new set of issues that we have to face. And I think it's fair to say that once these children leave the hospital, the system that they face out in the community is not nearly as good as it is in the hospital. So this is a place where philanthropy can really have an impact. At the Lucille Packard Foundation for Children's Health, we have taken on this cause as our major focus. And interest.
You mean organizing around chronic ailments?
Yes, we call it Children with Special Healthcare Needs, is
Great.
The way we refer to it. And we started off with a set of interviews with families, and I think one of my favorite quotes was a mother who said it was easier for her to get access to Packard Children's Hospital for open heart surgery for her child than it was to get a wheelchair after they left the hospital. So we have convened a number of experts to help us define what the system ought to be, what a good system would look like, and then how do we work to get there, and trying out some various models, and of course evaluate as we go. We're focusing on California, but to take a quote from Tolstoy, who you remember said every unhappy family is unhappy in its own way. I would say every state is broken in its own way in how it takes care of these kids. Excuse me. Now I'm guessing that this kind of work is going on in other states and probably at some of your, I'm seeing some people nodding around the room in your children's hospitals. It's a very important thing because these are the kids you're taking care of. So I think there's probably a lot of room for shared learning among all of us, and I hope that will be an outcome of all of this. And I have to say, beyond the dollars, the philanthropists who care so much about kids and their health can have, this is all about policy changes, and we can have a lot of influence on policy change too, beyond our dollars, because we are people of influence in our communities and in our state capitals. So I would encourage everybody to think about that aspect of it too.
Phil, one recurring theme over the past couple of days has been that a family's socioeconomic status tends to be the best predictor of the type of health care they're going to get. How does your work in philanthropy fit into that?
Yeah. Well, first of all, let me just start by saying and agreeing with you that those of you in this room who've served as philanthropists or leaders of Children's Hospital have our deepest respect. And I think that philanthropists not only, as Susan said, really make a difference in policy, they serve as a face to change. They really guide us and help us to take on some very big and important challenges. Disparities is very much consonant with where healthcare is today in this country. We all know that we're a nation that still lacks an effective healthcare system. There is a lot of need that is unmet despite the fact that we're spending $2.6 trillion on healthcare in this country. And children's hospitals play an absolutely critical role. They serve as a safety net. There isn't a child in a community in this nation that really gets turned away by a children's hospital. They will continue to provide care regardless of the ability to pay. But as Susan alluded to, and I would certainly underscore in my years as a pediatrician and now as the leader of a medical school, there is a wide gulf between what happens in the setting of care provision and what happens in our communities. And there's a very interactive relationship between the two. It is true that the world that one is born in predicts the outcomes of disease. The fact that many of our communities we're facing as a nation, indeed as a world, we've spoken about it over the last 2 days, the rising epidemic of obesity is disproportionately aggregated to certain members of our community. They have less access to appropriate and good nutrition and more access to fast foods that promote obesity. So these lifestyle changes that become very much part of the culture that we're part of or that we're born into can affect one's very outcome of health. And I think that the community here, the donor community, the leading community, the pediatric community, can truly make a difference by recognizing that it's not just about the safety net, that I think we've already provided for, but it's about the ability to push the agenda forward, whether it's political or whether it's in public-private partnerships, whether it's in new research agendas that allow us to articulate new blueprints for how to face some of these challenges that really makes a difference. We can overcome a lot by our shared partnership.
This socioeconomic thing, is that particularly prevalent with what I called chronic diseases, but perhaps I should call special?
Well, I don't think that chronic disease per se is a socioeconomic disorder.
Because you said obesity and...
Yes, because it is, right. It is disproportionately aggregated. I think that is true, but it's becoming very much part of a national enterprise as well. But I think that the ability to care for children who have chronic disorders is very different if one is in a setting where there is a lot of resource as compared to one where there's not.
Alan, the sequencing of the human genome, how is that going to affect prevention? How is it going to affect prevention, care, treatment?
Sure, I think that it's one of many tools that we now have that really will make a difference in how we approach children's health. Clearly makes prevention much more of a possibility. The real power of the human genome sequence, having that in hand, is not, as many people look at, being able to calculate individuals' risk for disease. That is a powerful tool. It's wonderful. But its real value is to show us the actual biological pathways of disease. We, for eons in medicine, have basically described disease and thought about disease based upon its symptoms. If you come into my office and you're wheezing, I will say you have asthma, as though that is one biological entity. It's not. It's just another way of saying you're wheezing. And there are many different biological, if I'm feeling really erudite, I might say you have reactive airway disease. It means you're just wheezing, that's why you came to me. But I need to say something different so you value the encounter. In fact, of course, there are different kinds of biologies that lead to asthma. Sometimes it's an allergen to a specific allergen that makes that happen. Sometimes it can be to cold, sometimes it can be to exercise. But sometimes it's also because one has a particular variation in your genome that's led to a particular form of asthma. If we try to treat all asthma in the same way, just trying to treat the symptom, not the biological cause, sometimes it happens to work, sometimes it doesn't. If we can identify the biological pathway and really focus and treat that, we have much better tools for treating effectively. And obviously, if you want to prevent something, it's very difficult to do prevention if you're just focusing on the symptom. You need to prevent based upon the cause. So I think the kinds of tools that we have in modern biology, the genome sequence being a key one, really allow us both to individualize care, but also very much to understand health and disease both. Because in fact, there are also genes that have something to do with conferring health. For instance, why is it that certain women who have a mutation in a gene that can often cause breast cancer go their entire life with that mutation and never develop breast cancer? Do they have other genetic variations that might be protective? Is there something that they're doing in terms of their diet or environment that somehow is protecting them? Those are things we also need to understand. So again, having the tools of our genome sequence to help us do that lets us both understand individual health but also biology.
Cindy, I said at the outset about thinking globally but acting locally. I realize you're the person here who's also acted globally, and you've been all over. First of all, tell us a little bit about what you've seen as you go around on global health, and maybe if I could push you to talk a little bit about how advances that might happen in children's hospitals around this country can be applied globally, and we can see the ripple effect.
Well, I've worked only on a global level for the most part. I worked initially a little bit with the Native American population in Arizona. The similarities are they're very stark, actually. From a global level, everything that is done, that you do from either a research level, a consumer level, a production level, whatever it may be, affects the world. And it affects directly what happens in the little village that I work in regularly in Africa. Because in my opinion, around the world, the philanthropists are the ones that put this whole thing together and take what you provide from a research standpoint, from a consumer standpoint, and deliver it on a much lower and much simpler level, which says a great deal about how we can provide care around the world. In my opinion, it's most important at this stage, particularly in this world, that we consider the impact of security. That without security sector reform, particularly in Africa, healthcare becomes irrelevant. We can't have healthcare. We can't provide the opportunity for nursing mothers or for infant mortality rates to drop, et cetera, unless we have security sector reform around the world. And as you know, right now, we live in a very dicey existence. What you do and what all of us do from a philanthropic, and I call myself a philanthropic activist, not a philanthropist, because I believe that philanthropy is moving more towards the activism role rather than just simply writing a check or being involved on a local level. I believe everyone is beginning to look more globally, and that's most important. And with that said, I mean, it all sounds very lofty and very, from my standpoint, very almost Disneyland-like. But it is always the American philanthropist and the American group that is in first, and we are always the last to leave. And I'm not being critical of any other country, but when you see what takes place around the world and where the needs are and where the needs are met or attempted to be met, it's usually a North American philanthropy that's doing it. Mm-hmm. And that's why I encourage everyone from the philanthropists that are in the room to not only maintain what you're doing, but to increase it if you can. And in this time, in these particularly dicey economic times, we're going to rely even more on philanthropy. Philanthropy is going to be the link, in my opinion, to being able to provide the best care that we can for not only our children here, but our children around the world.
Tell me a little bit about what you do in the African village. Where is it?
I work with a group called Eastern Congo Initiative, and we primarily support community-based organizations, whether it be nursing mothers, like I mentioned, infant mortality rates, nutrition, vaccination, water, basic water needs, et cetera. So we fund and help organize small community-based organizations in Eastern Congo, which is, as you know, is where the strife is right now.
Since you're married to a policymaker, how does philanthropy affect policymaking, do you think?
Not enough. I think philanthropists have an incredible voice, and collectively, philanthropy as a whole could, I think, change policy. I think we need more of your voices in Washington, particularly. Because as you know, in Washington, the squeaky wheel gets the grease, and the more noise you make about the need both locally and globally, the more it's going to happen.
Susan and Phil, you're both nodding. How do you think the notion that if you invest in children's health, you get a lifelong payoff, how do you think that affects philanthropy, and how can that also affect policy making? Either one of you, but
yeah. Can I just make a link before I even get to that, to the wonderful work that Cindy is doing, if that's okay?
Sure.
Because I think there is an example that certainly I've seen where philanthropy has transformed the way work is happening in developing nations. So a number of years ago, when I was working at the National Institutes of Health, the disease which we now know as HIV disease and AIDS came about. And while we were into our work in pediatrics, parenthetically, the world was abandoning pediatrics at that point. It was not center stage anywhere. But there was a woman named Elizabeth Glazer from Southern California who came to visit with me, and who herself, with other philanthropists in Southern California, transformed the face of AIDS research, led to, in essence, strategies to prevent and treat the disease in this country, and then to be able to export the findings here to really impact nations like Africa, where there's such more greater degrees of this infection even today. So the interconnections are enormous that happen. To your question earlier about how do we make a difference in terms of lifelong payoff, well, coming back to Alan's comment, we're at the stage where in the very near future, we'll be able to predict the early risk indicators for on a biological level that will forecast how we'll do as children and adults. I think this is within the decade, if not sooner. That means that pediatricians have the opportunity to influence the care of children into adulthood and set the stage for outcomes that will transfer across the many decades. Now, the one factor that I would add to Alan's very elegant description is that we do have risk factors, and we know that we'll be able to sequence our genome, but we also know that the environment and many other factors impact on how those genes are expressed. And as we learn more about that at an individual, community, and population basis, I think we have certainly the beginning of an opportunity in pediatrics to truly be transformative in a nation that needs transformation in terms of its health care.
Mm-hmm. Susan, Phil has just really made the point that an investment in a child's health is an investment in lifetime of improved outcomes. How has that provided an impetus to you and to your philanthropy and to philanthropy in general?
Well, I think it's fair to say that for probably most of us in this room who give to children's hospitals, that kind of philosophical underpinning with all of Phil's wonderful explanation probably isn't what motivated us. What motivated, at least what motivated me, and I suspect a lot of you, is we walked in the door of our children's hospital and we saw the children there and we saw the everyday miracles that happen at all these children's hospitals. And it doesn't grab everybody the same way, but I'm sure for all of us, it really spoke to us. And that's why we became philanthropists to our children's hospital, I would guess. But That's not to say that the deeper story is not critically important for ensuring the well-being of children across the board. And I would say that the way this can play in partly to policymakers, but beyond that to the public, I think we haven't done a good job of telling our story to the public. So we haven't taken this emotional reaction on these children and presented them out in the public. And one of the indicators I would say of that is the reaction of the public to the Affordable Care Act, frankly, and why the public doesn't embrace at least covering all our kids. I don't get that. And I don't get, frankly, I won't name the state, but a certain governor recently announced that he's going to decline all the expansion of Medicaid into his state. This is going to leave millions of children without insurance and without access to health care except through the emergency rooms in the general hospitals. And yet the people, the public, is not rising up in outrage about this. So I think we just haven't really told our story in a meaningful way that to the people, and the people can influence the policy.
Alan, I see you leading forward there.
I'm really thinking about Susan's comment about what has motivated many philanthropists to be involved in children's hospitals, simply walking the door and seeing that. We shouldn't take that for granted. That's a relatively new event in human history. If we think about our value of children, I mean, you can look at art of the 17th and 18th century, and children in any kind of painting are simply little adults. It took a long time for society to even recognize, and certainly medicine, to realize that children were not just little adults, that they had their own lives, their own needs, et cetera, et cetera. And in fact, of course, it wasn't long ago that families didn't even particularly value their own children. In an era, many eras, when you thought that there was a great chance any specific child of yours was going to die, parents did not invest in those children, either financially or emotionally very frequently. It's only since we've really had a great probability that our children would survive that people have been able to invest emotionally in their children, et cetera. And it's even more recent that we've begun to invest in other people's children. For orphanages used to simply be warehouses to keep kids out of sight and somehow confined kind of thing. We've gotten as a society way past that, but we certainly haven't gotten as far as all of the people in this room want us to be. And I think that's why the folks in this room, is the point that's been made before, the value of philanthropists' involvement in Children's Hospital goes way beyond the money. It is because you are community leaders. It's because you bring other perspectives to bear besides the narrow medical one. If we really want to improve children's lives, if we really want to bring forward in society prioritizing children, this is part of a continuum. I think all of us in this room are too eager about this to wait for history to slowly sort of continue to unroll. And the question is how we can use the force that all of you have to really catalyze this so the change to really valuing all children, not just our own, becomes a real societal priority.
Cindy, does this transcend partisan politics?
Oh, it always has to me. I mean, I'm astounded when I take a look at the partisanship that's occurring in Washington right now, because we get nowhere. I mean, it's an understatement. I'm not telling you anything you don't know. But it affects not only what you do on a local level, but it does affect globally children's health care. And unless we can get past the impasse, your local children's needs are never going to be met, hence the research, hence it's a domino effect. I see what you do locally from a children's hospital level that filters back to places like Africa and others as an investment in peace. These kids, if they are healthy and if they are at least have access to something, some knowledge, something, they're less likely to pick up a gun, and they're more likely to pick up a spade and a hoe and start gardening or start feeding themselves, farming, I'm sorry. I know this is very broad and very lofty, but I've seen it happen, and I see it on a daily basis. So I think partisan politics all the way up, everything is affected by what's going on in Washington right now.
Let me ask both you and then Susan, and see if anybody else want to come in. What's the role for the private sector as well as the public sector in philanthropy in dealing with this? Susan, you want to start?
Okay, sure. Well, if you think about the private sector in this country, they actually pay for most health care, right? Because they're buying insurance for their employees. And so this evidence that we have that if you invest in children early, I don't know what the impact is going to be when we know too much about how people are going to be when they grow up, but let's set that aside for the moment. So if we have this evidence that if you invest in kids when they're young, they're going to have a much healthier adulthood, you'd think that the private sector would embrace that, because after all, they're the ones who are going to reap all the savings from the insurance policies that are paying for that health care. And so again, I think it's a story we haven't told, and that philanthropy could certainly participate in telling that story. I think there's a lot there, making that connection. But what's been already said, and I'll just say it yet again, the philanthropists here in this room, a lot of us are connected to the private sector, most of us, because after all, that's where the money comes from, right? So we are the private sector, and we again have the opportunity to use our voices to influence our colleagues in the sector to take this on as an important cause.
The reason I turned to you, Cindy, is you're the person with a foot in all three camps. You've run a major private company, you've been a major philanthropic activist, and you know policymakers. So how does that all fit together?
I don't know if this is good or bad. I think most importantly, in my opinion, collectively, children's hospitals from around the country, I think should continue to engage the way that you are today here and have been, because collective knowledge and collective activism will, of course, increase the ability for all of us to raise healthier children. Private sector is extremely important, and every time I go out, what I hear is we can't rely on the government anymore. We're going to have to step up to the plate as a private sector. And I wholeheartedly agree in that, because it's your investment in your future, your children's future, your community's future. So I see philanthropy and private sector really beginning to take the top part of the umbrella in all of this, because as things decline in Washington and other places, I don't see, we have no other place to go. And it's the right thing to do.
I'm going to ask Phil and Alan to chime in and maybe also broaden it to how do we create a voice for children?
Yeah. Well, it's a great question, and I do appreciate the comments that have already been made. I'll give you an example that's happened just in the last 8 years, and it's a public-private partnership. It happens to be in California, but it was stimulated by a parent of a child with diabetes. So Bob Klein, who's a parent of a child with diabetes, became concerned not about just the way we're currently treating the disease, but how we might discover new ways of doing it. And he looked toward the burgeoning field of stem cell biology, regenerative medicine, as a way of being able to do that. Now, at the time, this was, as we all recognize, an enormously political topic for all the ethical, moral dilemmas that we face, but he, together with a number of private investors as well as philanthropists in the state of California, forged a public-private partnership that ultimately led to a proposition called Prop 71, which created the California Institute of Regenerative Medicine. That institute, at $3 billion, has changed the face of stem cell research in this country. We're about to lose it to China and other nations, but we've seized it and we've made amazing progress. It will take time before these discoveries change the fundamentals of disease as we know it today, but it's a little bit like, we might have been simply worried about new iron lungs as compared to discoveries for the treatment of the prevention of polio. We might be able to deal with diabetes by fundamental research that leads to regenerative medicine and replaces the deficits in the pancreas as ways of really changing lifelong disease. So this is about research as well as it is about community benefits and support that fuses them together in a public-private partnership.
Let me pick up on that, because I have sort of a theory here, which is you're being at Stanford, you know that, say, 50 years ago, Frederick Terman creates public-private partnerships. He's the dean, I think, of the engineering school back then, a provost.
Absolutely, yep.
In basically the information technology sector, which allows industrial parks of Hewlett-Packards and many other companies to grow up. Now we're moving into a new era of technology, which is a biotechnology era. And I know Stanford and I think also Harvard, MIT are creating these parks where a Boston Children's Hospital and Harvard Medical School and Genzyme or whatever may all work together in these parks. Do you see children's hospitals playing a role in those type of consortia?
Absolutely, and I see foundations and industry as playing a critical part in that relationship. So we are, just as is in the case of Boston, and I was at Boston Children's Hospital before I came to Stanford, we are a center for biotechnology. But there have to be also champions as well, and I'll give you an example. It was champions that defied expectations in the world of cystic fibrosis, and the Cystic Fibrosis Foundation that really led in partnership with a company in Boston called Vertex to develop one of the very first drugs aimed against one of the unique mutations in cystic fibrosis that will change the face of that disease. It's a partnership between leaders in pediatrics, between industry and foundations, philanthropy and support, that created a new fusion product that will ultimately explode in new discoveries and hopefully into significant treatments for children with one of the most common gene mutations that we know about.
Alan, I had a couple questions for you, but let me let you comment on these two things
just
first.
Expanding really, in the private-public partnerships are invaluable and take many faces. For instance, you will recall that I mentioned yesterday the genome-wide association studies. The first of those that were done were actually funded because Pfizer came to the NIH and said, we have some monies available. What, in terms of genomics research, do you think might be important to do? And we explained to them we thought we were just on the cusp of being able to launch these genome-wide association studies. It would be wonderful to have funding to do that. And Pfizer gave over $10 million to do that because they realized this would provide knowledge that would be important to the field, might lead to much more informative drug targets later on. They were very willing to say this is not proprietary because we wouldn't do it as a proprietary relationship. We said, give us the funds, that we will use it to do peer-reviewed research. So we were able to take those funds and then give those to deserving academics who applied in the peer review process to be able to do the original genome-wide association studies. Pfizer, no sooner than all the other drug companies, was able to access that information once it was provided to then be able to do lots of things which we hope will lead to drug targets, which would lead to drugs that Pfizer and others can take advantage of. There are many such opportunities and many such examples. We had one really involving children in my own institute at NIH, Mars Incorporated, the third largest confectioner in the world, but also, you may not know, the largest maker of pet foods in the United States, came to us because they were very interested in animal-human interactions. And might we be willing to, again, receive money from them and make sure it was used wisely to do exploration about this? It turns out, here's a somewhat sobering statistic, more children in the US live with a pet in their home than live with both biological parents in their home. So in fact, the interaction of children with pets, particularly ill children, it turns out, but children in general, is a very important part of child's growth and development, but something that's almost never been explored before. So we were very happy to do that partnership to, again, be able to fund academics to explore this interaction, to understand it a little bit better in ways that could improve children's lives. So there are lots of, I think, creative ways and one can look at private-public partnerships. And it's not just often the money from the private organizations, just as it's not just philanthropist money. It's often the different way of looking at questions. It's the entrepreneurial, we're not willing to go at the slow bureaucratic pace, let's move this up kind of spirit that can really be helpful as well.
Along those lines, it gets to the question I was going to ask, which was, we've heard Cindy talk about how even things done at children's hospitals around this country have a ripple effect globally. And so does the whole spirit of putting children first, allows us to act globally. Does it work the other way around much? In other words, are there things happening around the globe that we should be importing, both in terms of treatment, but maybe even in terms of policy?
Well, absolutely. I mean, a very good example of that is now several decades ago in Bangladesh, new therapies were developed for kids with severe diarrhea. And they were developed in Bangladesh because what Bangladesh did not have was much technical availability of intravenous solutions, intravenous access. What they did have was families who were very interested in their kids and were willing to devote their time and energy to seeing their kids get better. So oral rehydration solutions were developed, whereby kids with severe diarrhea could simply get an oral supplement that would get them back to health. That proved so effective in Bangladesh that we imported it to our emergency rooms. And it changed the way that pediatric and children's hospitals cared for kids who came in for dehydration, usually due to diarrhea, but sometimes for other causes as well, so that sometimes you still need intravenous, but you can often get by with oral rehydration, allow the kid to return home much sooner, allow the kid obviously to have this experience with much less pain, et cetera, much less trauma. So there are many examples like that in fact, research, we used to think, I think of research in the third world, the developing world being a sort of, Lady Bountiful. We in North America will take our wisdom to the third world and employ it. It's really a bi-directional kind of thing where, in fact, if you want to do effective research in the developing world, it really takes people in the developing world who have expertise in research to frame the questions, to carry it out, et cetera. But in doing that, we in fact learn much that's of real benefit to American children at the same time.
I see you nodding, Cindy.
I've seen this happen. And there's a benefit on both sides. And as this trickles down from the local hospitals into other parts of the world, there's great benefit to it. And probably, in my opinion, one of the largest benefits in all of this is the example that we set by placing our children first, because all too often in countries around the world, children are disposable. And so, in my opinion, just the awareness and the involvement in the work is extremely important from a local level all the way down, because, like I said, all too often these kids are just ignored.
That's the theme of this conference in a way, which is how do we get a mindset where we put children first? Let me ask each of you to comment on that, starting with Cindy, and then I have a question for Susan at the end too.
Well,
how do we get an advocacy thing coming out of local hospital philanthropy?
Well, I think in many cases social media can be very helpful with this. You were talking about being innovative about getting the message out in a broader fashion. Local hospitals, local children's hospitals are at a great advantage because you can develop inexpensive tools to get the message out. And I think education and messaging is the most important thing you can do with regards to placing our children first and making sure that's a message and an understanding that we have first and foremost.
Alan?
Yeah, I think at our institute at the NIH, we talk about our job is to bend curves. If we look at those curves about infant mortality that we showed yesterday, if we show curves about the rate at which research happens, our job is to bend those curves in a favorable direction, of course. And I think very much that's our job here, is to bend the curve that I've talked about before and many of us are aware of in terms of children becoming in some ways more important in our discourse, in our priority setting, et cetera. We need to bend that curve. We need to accelerate that. And I will tell you, coming to this meeting, I had some hopes that maybe something would happen here. A, that the scenarios would be helpful for us thinking about the future, but B, that getting together over a couple of days, we might be able to start a real sort of catalytic kind of movement here. And I wasn't sure that was going to happen, to be honest. But what I've seen over the last couple of days, I really think that there is the germs here of something that really could become a movement. And so what I would think perhaps is to go forward with the momentum that we have here and to then have some smaller group representing all of us come up with some really concrete action items. This was, I think, the meeting to organize the spirit, to see whether people were engaged in this, and I think we've, to my eyes anyway, we've proven that. So the question is, taking that momentum, how do we actually crystallize it against doable action items that we can really unite around? And again, very much to go back to the point that you made before of thinking globally and act locally. That's the part of the power that children's hospitals bring to this. Trusted, valued members of the community that really are focused on children, that bring along with them the wisdom, the energy, the creativity of the trustees, of the philanthropists that support that work. That kind of energy and that kind of ability is something that I think we could really galvanize in a way that both has a sort of national kind of flavor to it, but is individualized to the local situation of each community.
Alan, how do we do? Bravo. You've been given the charge. How do we do that? Putting children's health first, and also the overall context, putting children first.
Yeah. Well, I think Alan, I would applaud as well, and Cindy for stating it very, very well. I think one of the great advantages and opportunities is that children's hospitals are really deeply valued in their communities. They are local phenomenon. They bring people together and they become learning laboratories for how to deliver care, how to improve care, how to create new preventative strategies, how to really engage in the health of the community, and it is transcendent beyond that. So there's a lot to value in one's own community, in one's own children's hospital, and I hope each of you in your own communities and own states continue to support your children's hospital. Each one of them individually makes a difference. But then I do agree with the point that Cindy and Alan made. We need to find a common voice for some of those issues which are affecting the health and well-being of children and their families. This is a place where we can get in, have a discourse that transcends political debate, because it does put children first and does state that if we can collectively find just a couple of examples where together we can work collaboratively, whether it's a problem, a health problem, or a health disparity, we can really make a big difference. So I think that is the dividend, the outcome for this meeting, like Alan, like Cindy, that I've really taken away, and I'm very excited about.
So Susan, when you invest in a local hospital, are you investing in something larger?
Well, of course, as I said, we all just love our local children's hospitals. Otherwise, we wouldn't be investing in them and we wouldn't be here. And of course, they take care of the sickest kids. And that's a lot of why we do this. But happily, most children don't ever see the inside of a children's hospital. They don't see the inside of any hospital except for the first few days of life. And then maybe they go to an emergency room if they fell off the jungle gym and broke an arm or something. But happily, most kids don't need the children's hospital. But there is something much larger. Of course, there are many, many things about a children's hospital that go well beyond taking care of the sickest kids. And you all know what these are, but I'll just mention a couple of them. Of course, a lot of them are academic institutions, the academic investment in the research, in the finding cures and prevention. We've heard wonderful stories about that. These are centers that train pediatricians. Almost all of the pediatricians and certainly all the subspecialist pediatricians that take care of the children, wherever they are in the United States and Canada, have trained at a children's hospital. So we're supporting all of that effort. Many of our hospitals invest broadly in their communities and caring for kids, whether or not they're in the hospital. Of course, there's a lot of outpatient activity, but even beyond that, there's a lot of work outside the walls. I think we saw a picture of a children's hospital with we've all seen these in our board meetings and so on, all the connections and partnerships that we have all around us in our community. So they certainly have a very broad impact in the community. But it really can go beyond that, and we've been talking about that here as a group. We represent, those of us who invest in our children's hospitals represent by far the biggest block of philanthropic dollars that are invested in children's health. I think it's something like $1 billion, is that more or less right, a year, that go into children's hospitals from all of us, and that swamps everything else that philanthropy invests in children's health. So we're it, folks. We are the ones who care about the health of our kids. And so I think that when we step up into leadership roles, when we engage others, when we talk to our friends in our communities about it, when we tell stories about the impact that we can have, when we try and influence public opinion and policymakers, we can have a much broader impact beyond our children's hospitals. And I think that these have been wonderful ways that we can come together with our collective power, and we need to do that. We can't let this end in a few minutes as we all go out into the beautiful day outside, and I'm sure you're all wishing you were out there, but anyway, it's gorgeous out. we need to step up as leaders and come together and make something happen out of this forum going beyond.
Thank you. Ann, did you have a question? Yeah, Ann Bass, I think you had a question. So why don't you stand up if you would?
Well, I did have a question, but I think Alan pretty much framed much of what I wanted to ask. So I think my remarks will be pretty much focused on what you had to say about a national voice for children. To be perfectly candid, throughout the retreat, I've been very excited about hearing these innovative, extraordinarily effective, and even sometimes revolutionary modalities that are coming online. But I've been a little bit disappointed that we hadn't heard a lot about how we might be able to take the collective wisdom, excitement, and dedication towards children's health and their issues, and to focus this more broadly into some kind of a national movement. I've been chagrined for many, many years that children always seem to be at the short end of the spectrum in terms of receiving care, receiving notice, being front and center with respect to policymakers. And I've always wondered why it was that there hasn't been a national organization, and I'm not sure exactly how that would be constructed, but something that would have the voice of the children first. And I think when you look around and you look at effective special interest groups, and I think children certainly are a very, very special interest, this would need to be something that would have the power and the commitment of entities like the National Rifle Association in terms of their reach towards legislatures, and AARP, which is another very effective organization. And I think we need to create something that is so effective that lawmakers would ignore us at their peril. And just one more comment about all of this. I think we need to figure out a way of developing a dedicated funding source for children's issues. All too often, money that is passed through legislative bills or whatnot can be scrapped in a moment's notice through some sort of budget cut or whatnot, and it hurts the children the most. And so several years ago, you all probably remember, on your federal income tax, you could check a box, and your dollar or whatever it was could go to the support of publicly funded campaigns. Well, we might have something that would enable us to check a box, and it could fund a dedicated, inviolate fund of resources that could help children in some way or another. But those are just a couple of ideas, and I do agree with Susan and everyone on the panel that we need to take the collective ideas from this conference and move out aggressively and actively and really promote children to the best of our ability in the best way we can.
Wow, thank you. That's a perfect summation. Usually we come out of these Aspen meetings with action plans about how we're going to lead thought into action. I see Tony Verstandig nodding. Besides being involved in Children's Health, she runs our Middle East programs. And when we come out of these meetings with a Middle East idea, it is usually very, very complicated and takes a long time to implement. Coming out of this panel and these 2 days and out of Ann's talk just now is a very simple idea, and I hope both the people on this panel, maybe Ann, Jane Wales, we can put together a working group so we don't just go forth thinking it's a good idea, but we go forth implementing it as an idea, is a very, very, very simple idea, which is a national advocacy movement for putting children first. A national advocacy movement like the AARP does for retired people that puts children's health first and puts children first, because those two are combined. I do think it is perfectly situated to be founded on children's hospitals, community hospitals, and local philanthropists who lead those efforts. So I really hope that will be the action call coming out of here, which is finding a way politically in the private sector and in the philanthropic sector to put children first. Thank you. Susan, you're our co-chair. I don't want you to end the conversation, but perhaps you can end the meeting. The conversation will continue. Thank you, Susan.
All right,
Susan
great.
Pacador.
Well, everybody's all fired up now, right? We're going to go out and make a difference, and it's going to be great. And we've had such a wonderful few days here together. hearing so much fascinating material, sometimes hard to absorb it all. I think there'll be hopefully a website afterwards that we can go and look at and rethink all of the stuff that our brains have been flooded with. I would like to extend a special thanks to all of our fantastic speakers and panelists and so forth who really got us thinking. And as you heard, we think this is an unprecedented meeting, a group of people like this, philanthropists around children's health care and children's hospitals. And so we really are the ones who can put children first. So a lot of what I was going to say had to do about where we're going to go from here, but I think we already heard about where we're going to go from here. I think it's very exciting. I will just give you the mundane point that you have an evaluation card, everybody, and this is your opportunity to speak out about how you thought this was, and maybe an opportunity to jot a note or two about how you're really interested in seeing this go forward, or whether you think it's a distraction from your own community, or whatever you want to tell us. So this is your opportunity. And we're really hoping that people will want to do this again, that the forum will not just be a one-time, one-year collaboration between the Aspen Institute and the Woodmark Group, but this will become an ongoing meeting every year where we can come back together, get re-energized. That's such an important thing that happens at these kind of meetings, and get ready to go back to our communities and make a difference. So now we can all go out to this beautiful day, go home to our own communities. Maybe you all have other wonderful travel plans. Wish you all safe travels, and thank you so much. And let's just do it and make kids first. Thank you.
Bravo. Thank you all very much. Thank you, Phil. Thank you. That was beautiful, Susan. Really beautiful ending.
Thank you, Susan.